CPAP is continuous positive airway pressure. It's been in the hospitals for about 50 years, widely adopted for EMS now. Actually, in some agencies out on the West Coast, it's mandatory for on the ALS side. So what this is not to be confused with home CPAP. What people use at home to keep themselves from snoring, it's a little generator, a little blower. They put a mask, they sleep with the mask on at night, and it keeps them from snoring, keeps the airway open. It's the same concept, but the home CPAP machines just use ambient air. The ones you guys are going to be using are going to be running off your portable bottles. And the ones at home, you can put humidifiers on there, you can plug them into the wall, bells and whistles. The devices you're using here are completely pneumatic. There's no power other than the pressure from the cylinder. CPAP, go ahead, your question?
There's CPAP and BiPAP, what's the difference?
The difference between CPAP and BiPAP. CPAP is continuous positive airway pressure. It's one set pressure throughout the breathing cycle. BiPAP is bi-pressure support. So you can actually set inspiratory and expiratory ratios. So for a COPDer, their issue is maybe exhaling, so you could set an inspiratory ratio of 6 and an expiratory ratio of 2, and vice versa. In EMS though, BiPAP becomes really expensive and somewhat impractical because then you're setting tidal volume ratios. You've got to calculate, you've got to do a proper patient assessment and then start calculating ratios with it. In EMS, CPAP works the best because, hey, it's one pressure and it works throughout the breathing cycle for the patient. These CPAPs have been used in the hospitals for about 50, 60 years. They use it to wean patients off of ventilators. They take them off the vent and then they put them on a CPAP machine, and it just slowly keeps the airway open, keeps the alveoli from collapsing until they can stay open on their own. This is your current landscape. The green states are states that CPAP's been approved as an EMT basic skill. Every time I turn around, another state's getting added to this too. You're seeing within the next 2 years this whole map will be green, and I won't even be able to use the slide anymore because medical directors statewide are looking at this saying, geez, it's simple, straightforward, it's not invasive, it's reducing the number of patients that get intubated in the field, and let's just go ahead and make it a basic skill. So at some point in time, for California you're looking at about 1.5 years. Arizona, most likely, maybe within that same time frame. I think there's actually some more rural areas where it's becoming a basic skill upon medical director approval. One of the studies behind CPAP, large 300 patient study, you had 2 groups of ambulances. They threw CPAP machines on one of the groups. The other group just did standard protocol, what you guys are doing for moderate to severe shortness of breath right now. At the end of the 300 patient trial, the 150 patients that were on ambulances that had CPAP machines available, you had ended up with 13 intubations. The group that didn't have CPAP, you had 56 intubations. So you just show a dramatic reduction in the number of patients you'll have to tube out in the field just by having this available. Not only is it great to not have to intubate patients in the field, but one of the things that most of us don't think about is that there's a substantial cost in intubating a patient. Yeah, it's a couple bucks for the tube, but on the back side, a patient that gets tubed goes in the hospital, you get the ICU stay of 5 to 6 days, and then the rest of the length of stay in the hospital is sometimes 14, sometimes 16 days. Plus, that doesn't even count in the fact that if they pick up a VAP, some kind of bug associated with just being on a ventilator, other bugs in the hospital, some patients don't even come back off of being on a ventilator either. That's an additional cost to the hospital. So, if you put a patient on CPAP, most CPAP patients will get discharged within 24 to 48. It's a lot shorter stay time in that hospital, and Medicare reimburses up to 5 days. So anything past that 5 days, patients, the hospitals were getting stuck with the bills because most of your patients are on fixed incomes. So they see a substantial reduction in the cost, the back-end cost of the hospitals, just by having this available and not intubating patients out in the field. You had, here's a big hospital case study. Memorial Hermann Hospital, 9 receiving EDs in the Houston area. 2006, they had 1,200 intubated patients come through their receiving doors. They looked at that, and within 24 hours, half of those patients were being extubated. So they knew, okay, maybe not all these patients needed to be tubed in the first place. This hospital system actually rolled CPAP out for Houston Fire Department, Montgomery County, the ambulance groups, paid for the system, restocks the circuits, everything. 2007 rolls around, they end up the year with about 460, 470 intubated patients at the end of the year. So they saw a dramatic reduction in the patients coming through the doors that were intubated. They're coming in on CPAP. And then even if those patients that did need to be intubated, you keep them on CPAP, they get into the ED, and then it's a controlled environment. It's a lighted environment. They've got wonderful tools of the trade to intubate patients if they do deem it necessary at that point. So you see a lot of the hospital systems picking up on this too. So what is this? Continuous airway pressure. It's exactly what it is. It's higher airway pressure. You use that high pressure, it stents the airway open. It increases the FRC, which keeps the lung capacity a little larger. It keeps that open, gives you more surface area available for gas exchange. Keeps alveoli from collapsing, so you get patients with heavy pulmonary edema. Imagine a balloon, once it's closed, to reopen it's a lot harder than if it's already inflated. Minimizes the work of breathing for those patients, especially your puffers, and reduces the need for intubation, which I covered. And also reduces the diaphragm stress on them too. So some of these patients get really tired out. You get there, they almost have no energy left. Well, this is going to help them breathe without using all their accessory muscles. Signs and symptoms. I have this broken out because some agencies only approve it for CHF. Some approve it just for CHF and COPDs. However, here I believe in talking, it's going to be all moderate to severe respiratory distress. So
the indications listed for the protocol that's going to be released pretty soon: CHF, pulmonary edema, asthma, COPD, submersion. And I'm pretty sure it's supposed to be near drowning, but it says drowning or smoke inhalation. So it's pretty broad for what we're going to be able to use it for.
It's going to be near drowning. The issue with near drowning is you get that loss of surfactant in the lungs, especially now when you get a lot of saltwater pools too. The patient can get resuscitated after drowning. They're doing great, and then 12 hours later, they're back critical in the hospital because with that loss of surfactant, even though the airway gets resuscitated, it starts collapsing on itself. So getting that patient on 100% oxygen and on CPAP is essential immediately. So that's why it's indicated for near drowning. Some definitions for you. You guys probably already know this, so I'll just go through it real quick. CHF, left ventricular failure, just caused by age. There's no... They call it a disease, but it's something the heart after a while just begins to fade, and it can't keep up and regulate body pressures anymore. Pulmonary edema is fluid in the lungs, and then you've got CHF because the heart begins to fail, creates a backup of fluid throughout the body, and one place it backs up is in the lungs. For your pulmonary edema patients, this is what it looks like on the inside. This is your alveoli. These are your interstitial spaces around it. As the heart begins to fail, body pressures back up. Fluid perfuses out of the interstitial spaces into the alveoli. As the fluid starts to fill up, you lose that surface area available for gas exchange. You put the patient on CPAP, that higher gradient pressure in the airway actually pushes the fluid and it reperfuses back in the interstitial spaces. When the fluid's out, you get your surface area back and you can maintain adequate gas exchange. You're going to see this on your pulse oxes right away. Within a couple minutes, patient standing at 75, you can get him into the 80s really quick. Issues with COPDs, there's several different types. You've got your typical COPDs resulting from lung damage with your bronchitis and emphysema. Your bronchitis is an increase in the mucus in the lungs. The mucus builds up in the bronchial stems and constricts. So you get air trapping involved in the alveoli sacs, and the carbon dioxide can't get out. With emphysema, typically from smoking, permanent damage to the alveoli walls, chronic cough is indicated with that as well too, and over time you just get substantial damage to it. With asthma, a reaction, you've got a smooth muscle lining around the bronchial stems. When a patient has an asthmatic attack, they have a reaction to that, and it causes those muscle lines to constrict, which then squeezes the bronchial stems closed, and then you can't pass air through it as well. Here's a side slice of that. You've got your alveoli clusters here, and you've got your bronchioles here. You see the thin muscle lining wrapped around it. During an asthmatic attack, that muscle lining gets constricted. You use a reactive airway disease drug, albuterol, Xopenex, something that put in the bronchioles and relax that smooth muscle lining to open it up. The CPAP's also going to push the mucus through and break it up, so it'll push the bronchial stems open again, so you can pass air through, get the carbon dioxide out of the alveoli, and you're pushing in 100% oxygen, so you're diluting it out too. Contraindications for this. Are there any contraindications listed on the protocol coming up?
Everything that you have.
Everything up there. Okay. Patient has to be spontaneously breathing to be able to use CPAP. So, if they're in respiratory cardiac arrest, you can't put CPAP on them. Also, depressed LOC. If they can at least understand instruction, they might not be able to talk. Most of them can only get one word out per breath. If they can at least understand instruction from you, they're a candidate for CPAP. Go ahead, put them on there. It's the ones that are totally passed out, even though they're spontaneously breathing, but they don't know what's going on. They're contraindicated for this. Blood pressure. CPAP's been shown to drop blood pressure. You're doing that in conjunction with your nitro, which also sometimes drops blood pressure. So if you have a hypertensive patient, BP's at 90 and keeps dropping, you're going to have to discontinue use on CPAP. Any signs of a pneumo, remember you're increasing interthoracic pressure. You do not want to create a pneumothorax with this. Higher pressures can cause a pneumothorax. These devices are limited at 15 centimeters of water pressure, but if you see any signs of head or chest trauma on the patient, do not start CPAP on them because you could either create an additional pneumo, or if there's already one existing, make it worse. Per medical guideline, is there a
10 years.
10 years, okay. Different everywhere. 10 years or younger. The concerns there, usually medical directors look at that and say, you know, we're concerned about underdeveloped lungs and different pressures. Burns, fractures. The issues with vomiting and a nosebleed, you don't want to run the risk of pushing anything back into the lungs when you're putting a patient on CPAP. Now, vomiting is just what it is. Don't get that crossed with pulmonary edema. You set a patient up and all this pulmonary edema starts coming out. Go ahead and clear the airway, keep them on CPAP. It's the ones that continually vomiting into the system, you're going to have to discontinue use on that. Oh, this is going to be too hard for you to see. I'll just read it out loud. This is just a slice of different CPAP runs, things you'd run into. You get average CPAP times for patients. You get anywhere from 10 minutes all the way to 60 minutes. So this agency had really long transport times, plus sometimes you have wall time. This rural area was in a place where you only had part-time RT. Sometimes you get a patient into the ED, and there's nobody to transfer that patient over to, so they had to wait for somebody to set it up. Indications are all across the board here, all different shortness of breath. Degree of dyspnea, difficulty breathing before and after application of CPAP, and you go from 4 to 1, 4 being the hardest, 1 being the easiest, 5 to 1, 4 to 2. Now, 5 to 4. CPAP doesn't work for everyone. You're going to have some patients that you put them on there, they either sustain their current condition, or they don't improve, or they get worse. CPAP is not going to work for everyone, so you've got to know at some point when to stop it. If you don't see improvement within the first 5 minutes, go ahead and discontinue use. If the patient's getting worse, that doesn't mean keep turning up the pressure, that means discontinue use as well. Not everybody's going to tolerate and comply with CPAP. And then you get your SATs here. You go from 72 to 96. Some of them start 90 to 96. So you're going to see that's your best indicator on how well this is working. Look at your pulse ox. This is just this is an email I got. Good, well-run call. It's just you get your patient, they're in a con home, 77% SAT. They put them on CPAP. Within a matter of minutes, she's talking in full sentences. SpO2 is back up to 99%. I get a ton of these. It's just the point of that is how quickly and efficiently CPAP works on your patients. It's like D50. You put them on there, and with just a couple minutes, they're talking in full sentences. Color returns to the skin, and they're doing great. Quick comparison. Obviously, CPAP is non-invasive, whereas intubation's invasive. I'm just trying to put that comparison out there so you can see, hey, if I've got this alternative to tubing a patient, yeah, I know I've never heard a patient complain back because they can't talk and they can stabilize it, but if you've got an alternative, by all means use it. Procedure for this. Sit the patient up. Put them on your monitor. Obviously your pulse ox, obtain vital signs. Now you guys, this agency I got from uses sublingual spray. You guys use pills, but start your nitro first because once you put them on CPAP, you're going to have a mask sealed over their face. So do your nitro ahead of time. Then I'm going to show you how to set up the system. When you turn on your O2 cylinder, make sure it's as full as possible. If it's anywhere below 1,000, I wouldn't even recommend starting on that cylinder because you're just not going to have enough time on it. CPAP is very oxygen intensive. You're using the higher pressure off your portables. Your goal is going to be to get off the portable and get onto the house line of the ambulance. But if you go to a convalescent home and it's a long, drawn-out complex and it took you 5 minutes to get out there and then you start CPAP at the patient bedside, you know it's going to be another 10 minutes to get back in the ambulance, make sure you got a full cylinder to go in. Explain the procedure to the patient. This doesn't really do it justice. You really need to coach these patients. Your hypoxic patients are combative, they're scared, and you're about to put a pressure mask over their face and ask them to breathe against positive airway pressure, which is very disconcerting for them. So you're going to coach them through it. The first couple breaths are going to be tough for them, and then as they realize they're feeling a lot of relief from this, and then they won't let go of the mask. But up until that point, you really have to coach them.
So, Pete, are we going to have a change on that policy here? We're going to change our oxygen out of 1,000?
No,
Here?
we already have extra jump on the rig. We'll just have to swap it out, you know.
Procedure here, if you turn the device on a little bit, let some of the oxygen flow out of the mask before the patient brings it up to their face, because this will operate just like an SCBA turned all the way down. If you let it flow a little bit, it's just like if you've got your, you squeeze the bag a few times, they feel it on their face, they may be more likely to breathe through it. That's just a trick of the trade here. Same thing with instructing them to inhale through the nose and out through the mouth. There's no CPAP benefit for that other than it starts them to focus on their breathing. This says apply mask. I actually recommend giving the mask to the patient. Let them take it up and take the first few breaths off of it if they have enough energy and strength to do that. It gives them more of a sense of control. Now, titrate with CPAP. Is there a max setting on the protocol?
10.
10. So you're going to start them out at 0 or 1 and slowly bring them up. Now 10's your outer limit, your max, not your goal. This one says to a maximum of 10 to according to patient tolerance. Some patients cannot tolerate 10. You'll get a patient up to 6 or 7, sometimes 8 or 9, and they just start pushing back and they look like they're ready to pull that mask off, take them back down. The 2 tricks here, bring them up slowly, and when you do bring them up, if they look like they're fighting you, or and you're talking to them and you're making eye contact, thumbs up, thumbs down, if they just say it's too much for them, bring it back down. Don't try and crank everybody up to 10. And if CPAP's not working, that doesn't mean you just keep taking it up higher. It could be some other thing causing it. And then reevaluate, reassess, reassess. Every time the patient moves, just make sure you got a good seal through the system. Procedure, this says contact the receiving facility. Just let them know. So RT's got a BiPAP machine waiting for them. They can switch it over. Make sure you're continually monitoring the patients. You're going to see a decrease in the heart rate and respiratory rate. Pulse ox is going to go up. Now here, if patient condition worsens, make sure you remove the device and assist ventilation. So this isn't the magic of that's going to solve everything. There will be a subset that it's just not going to work on. Complications. I mentioned hypotension. It will drop blood pressure. You could cause a pneumothorax with it, so monitor your pressures on there. This particular device that you guys went with has a pop-off and built inside of the system, so you don't have to worry about, say that regulator breaks, starts kicking out 300 PSI, it's not going to go to the patient. It's a built-in safety. Corneal drying is just a product of, if you don't have a good solid seal on the mask, oxygen will start leaking into the eyes, and it burns. Oxygen is a drying agent. After a couple minutes that patient's breathing on it, they will try and peel the mask off if you don't have a good seal. Make sure you take their glasses off too, because if you try and seal it around the bridge where the glasses are, that's going to cause it to leak into the eyes too. And flash.
Cause them a pressure wound also.
Pardon?
You can cause them a pressure wound.
Yeah, it would be uncomfortable for them. Flash edema, what that is let's say you've got a patient has pulmonary edema, you put them on CPAP, pushes the pulmonary edema in the interstitial spaces. It's still there in the body. Even if you use a diuretic, Lasix, it takes 30-40 minutes to kick in sometimes. So, patient's doing great, pulse ox goes up, color returns to the skin, they're talking to you again. You take them off, leave them in the ED, or turn around, that pulmonary edema comes right back. And it comes back fast too, within just a couple minutes. And they're right back where they started. So once you've got them on CPAP, keep them on CPAP until the RT or the receiving ED doc can transfer them over and assess and determine what to do with that patient. Typically they'll put them on BiPAP. All right, let me just go over this real quick. I'm gonna hit that light switch for me. Okay. Components of the CPAP system. You've got your mask. Start there. Small, medium, and large. The yellow mediums are going to fit about 80-90% of your patients. For patients that you're having trouble getting a good seal on, while you're elderly, you can grab the smaller mask here. A nice, good mouth and nose seal. For your patients who are really claustrophobic or just have a big head, you can grab the blue mask here and use it for a full face mask or just a full mask. These masks all have little indentation grooves here. This is just for gripping. This is so your patient can hold it and they can bring it up, bring it to their face and breathe off of it. There's 4 posts on here for the headgear. So after they've taken a few breaths off of it and you want to give them a break and put the headgear on, it comes with the neoprene wetsuit type material headgear, so it's not going to pull their skin, pull their hair. And this is 4 tabs, and this is all latex free by the way too. You've got the 4 tabs here, 4 posts. You can cinch up and down, tighten, loosen. There's no right or wrong way with this headgear. I think the thicker part works better, at least on me at the base of the skull, because it pulls the mask back more and not up. Just put it on, wear it like a hat, doubles as a Halloween costume. It's stretchable and flexible, so if you even after you have this on the patient, if you need to flip it up, clear the airway some more, you can flip it up, or you can pull it off. Now your BVMs will fit this port too, so if you do need to assist ventilation with that patient, CPAP's not working, you can still use the same mask. And in the ED, most of the ventilators will adapt to this as well too. It's the same part. This is a medical standard size. Mask attaches to the breathing circuit. It's your 6-foot circuit here. We'll only fit onto one spot. And give it a pop. Make sure it stays on snug because you're building up pressure in this line and you want to make sure nothing comes apart on you. This exhalation port here swivels, so you can divert what that patient's breathing out away from you, at your partner if you're not getting along with them at the time. But no, in all seriousness, there's in each kit that the circuit comes in. This is your disposable portion of this. Mask, circuit, headgear, and HEPA filter. Each one of these bags has a HEPA filter floating around in there. Make sure you grab that HEPA filter, your N95 right here, put it right on the exhalation port here. That way, whatever that patient's breathing out, you're not going to breathe in. If you pick up a patient with pulmonary edema and they have TB, SARS, MRSA, a cold, anything, and they break up the mucus in the lungs and they cough, and it comes out, at least you've got it filtered and you don't have to worry about spreading with anyone else coming out of the back of the system. You've got a high airline pressure here, so whatever goes in on high pressure is going to come out at high pressure too. So make sure you're always using your HEPA filters on here. If you guys want to do capnography, your Zoll monitor sensor goes right in between. Your waveform's going to be a little different due to the nature of this device, but your end tidal is going to be right on. Make sure you set a baseline first before you start it. The other end of the circuit is another filter, so it protects the equipment from cross-contamination too. So once you've got the patient on CPAP, you have them completely locked out of the environment. If you guys want to pipe in some albuterol right in line with the system, grab your nebulizer. Fill it up. Put it right in line. What's great about doing nebulization, this is a demand-based system, so you're not blowing albuterol all over the place, and CPAP pushes it in. It gets it down in the bronchial stems where it needs to go, not lost in the mouth and the back of the throat. It pushes it all the way in. CPAP is a wonderful intervention for pushing albuterol in those patients' airways. And this, you can still run off your cylinder. Just keep in mind, if you're running all this off the same cylinder, you're going to drain it a lot faster. If you've got this at 8 liters a minute and you're running this off your high pressure port, really watch the gauge on your cylinder. This attaches to the unit. The outlet port has 2 little tabs on that breathing circuit. The way you attach this, there's 2 tabs here. Just push straight in, clockwise turn until both tabs lock up underneath the flanges here. Stays locked into place. You don't want this coming disconnected when you've built up an airline pressure on the patient. So make sure it doesn't get disconnected coming around a corner, doorknob, or anything. There's only a couple things on this device. Your high pressure inlet, your manometer, and your CPAP regulator here. That's it. On your high pressure inlet, since you're using high pressure, you do not need Teflon tape, and you do not need a wrench to tighten this. Everything's thumb tightened. This is a loose hex nut here, so once I turn on the cylinder, it's just the pressure will actually create the seal. So if you use a wrench, you're going to end up over-torquing it, probably breaking the washer off in here. So just remember, everything's thumb tightened on here. If you have trouble unscrewing this, make sure you turn the cylinder off first, drop the pressure, and then you can unscrew it. Everything in the world of CPAP is measured in centimeters of water pressure. This gauge here goes 0 to 20. For all intents and purposes, you just need to make sure you're staying in the green, which is 0 to 10. Where that needle sits at on exhalation is the CPAP pressure the patient's getting. And the reason the needle's going to fluctuate is because this manometer is being driven by a sensor port right here in the mask. It's not what the system said, it's what the airline pressure the patient's actually getting. And that's important because if you have a leak in the mask, or the system's not completely attached to the patient's face, you're going to see that on the gauge. The needle's going to drop, and you're going to know, okay, I don't have that completely sealed on the patient. The range of motion for this regulator here is not the green. The green just shows you which direction it can turn. It actually will take 3 full turns to get all the way up to max pressure. It takes about a half turn to even get it started. On the procedure I was talking about, you give it a half turn, it starts to flow a little bit. As it's flowing, you put it on the patient, and titrating is just starting to turn this and monitoring where that needle sits at on exhalation. Simple as that. You put this on the patient, and they breathe as you're turning this pressure up for them. Everybody knows how to use the Omeda Quick Connect system? Cool. Make sure your cylinder has one. If it doesn't, you can always just unscrew this and use the threads on this. If you don't have the Quick Connect system on this, or you go into an ED and they have, I have a slide of this. Hospital connections. Grab that light switch for me real quick. This is a disc port. However, off of these flow meters here, these Christmas trees will unscrew. If you unscrew the Christmas tree here, it will fit, but it will not be enough pressure to operate the unit. So make sure you're always going to the back off the high pressure ports. If you've got the quick connects, these Omidas actually, there'll be a wall line here, a green wall plate, and you can pop it into the wall plate and run it off the high pressure. Just make sure you're always going for the high pressure lines. Some EDs are different, but make sure you're not running it off the Christmas tree threads here. In the ambulance, I believe you guys all have the Omidas on the wall lines.
And they've been purchased for all the jump tanks too. So when we roll out CPAP, we'll have those in every ambulance.
Okay, system's on right now. I can breathe through it even with the dial turned all the way down. It's the SCBA setting. I'm getting the benefit of 100% oxygen through the system, just none of the benefit of CPAP. Cool. I'll breathe through the system, and my lovely assistant here will slowly titrate up that pressure to get me to about 7 or 8 centimeters of water pressure.
Can you turn the device? It's up to you.
No, thanks. It's not far enough, right?
Now we can't see it. It doesn't matter which way.
Just look for the green. This is a case of not going pretty well.
Okay. It's just about 10 there, so. Okay, simple as that.
And that's it.
Begin to start it. That still doesn't do it. Okay.
One of the things I talked about is if you do give it a little bit of turn, you can blow it a little bit. Patient feels it on their face, they're going to be more likely to take a first breath off of it. Plus, at that half turn, it's about 1 centimeter water pressure, so that they feel the puff coming in, and it gives them a little bit of relief. Okay, other things to consider. You should only hear inhalation and exhalation. If you hear anything other than that, you've got to check the system for a leak. So if I have this on a patient and it sounds like this, and they're breathing, first thing you want to do is check the mask seal. So if it's blowing, reach up, make sure it's sealed all the way. So, and that's the one place it's going to leak. You don't have a good mask seal. Sometimes, you know, if that foam's going underneath the chin, it's hard to get a better seal. Make sure it's on the front of the chin. If you can't get a good seal, sometimes you can get a better seal with a smaller mask. That's the first place to check for a seal, for a leak. Second place to check if this device is continually flowing is to make sure both of these tabs are connected underneath on the device. It's hard to do, but it is possible to actually attach one tab on, one tab off. Just make sure these are both attached properly. Push in, turn, make sure it's all the way on. Third place this device can continually flow is on this valve here. This exhalation valve here opens up as the patient exhales. However, let's say you're putting your capnography on or this gets dropped, this can get dislodged. This falls on the floor on the street next to the cot or something. Takes a pretty sharp blow to do it. Too sharp. This valve will get dislodged here. And what this sounds like, it's just like this. They're breathing, it's sealed, but it continually flows. If that happens, just pull back a little bit on it. So this little cap untwists, pull back, and make sure it seals on there. Probably won't see that, but if you do drop the circuit and it's continually flowing, you get kind of baffled as to why you can't get a good seal. Just double check, make sure that thing's sitting flat. You never ever want to let this flow without being on a patient's face. This is 100 liters a minute. This will burn through your D cylinder in about 10 minutes. Probably less than that. 100 liters a minute times a 2,000 PSI is probably about 4 or 5 minutes. It's going to go through fast. So make sure if the patient pulls it off their face to talk or something, just reach down and turn it off, or you can hold it against your chest or something. If they pull it off while they're breathing, it's going to continually flow. So just make sure you never let it continually flow. I had an agency that they did sublingual nitro spray. They would take it off, set it down while it's flowing, do their spray, assess the patient, then pick it back up, put it back on the patient, and wonder why they were going through the cylinders in 5 minutes. So just make sure you never let this continually flow. It's always got to be sealed on the patient. You should only hear inhalation and exhalation. There's no backup ventilation on this device, so if the patient stops breathing, you've got to discontinue use. They won't asphyxiate on the system if you run out of oxygen because there's an anti-asphyxiation built in. But if you do run out of oxygen, you might as well just use the mask and bag them because you're not going to be able to do any other benefit with the system on at that point. Questions so far? I have a case of masks here. I really encourage and strongly recommend that at least I think everyone should try it to feel what the different pressures feel like, what it's like to be on CPAP, so that you know what you're giving the patient. At the minimum, if you don't feel comfortable doing it here, when you get your equipment, at least take some time and play with it and set it up and try and breathe off of it. Question?
Do beards make it leak more, or is it more difficult?
This, you can find out. This foam mask will actually seal over a lot of facial hair. It gets a good seal over it. So, anybody got a lot of facial hair? Any Grizzly Adams? It will. It gets a good seal over it.
Alex, you're up.
It seems like this is mostly replacing just having to do a BBM on the patient right now, because we would normally intubate somebody that's already conscious and breathing normal anyway.
Right.
That's kind of nice, freeze your hands up.
All right.
People swallow a lot of air, they swallow a lot of oxygen.
They can. If you're on this system for an extended period of time and every time you swallow you're getting that oxygen in your stomach, and it can cause a little bit of gastric distension, at some point it might cause them to vomit. But that's why lower pressures are always better. If you get too high of a pressure, it's going to start pushing it in. The trip point, I think, is about 25 or 26 centimeters of water pressure, so you won't hit the trip point where it'll actually start pushing into the esophagus. But you can, if they're on the system and they're breathing and then they swallow, then that is going to trap some air in the
Is there a time limit to how long you can stay on that?
No, some hospitals actually use this in other parts of the hospital, and we've had patients on there for 2 days. So for EMS, no, I wouldn't be worried about the time limits at all. We have some transports that are 60 to 70 minutes sometimes. So come on up, somebody. I know it's always tough to be the first person, but come on up, try this out. We've got flavored oxygen here, pina colada. The unit can be run right out of the bag. There's grommets on both sides of this. So you can actually have the unit in the bag with the O2 line attached through the bag, coiled back up, pushed back into the bag. That way it's one less step for you. And then you can close this and then zip this up and over on the O2 line side here, so that when you go on scene, you can unzip this and it's already attached and just click it right in. On your circuit, take this out of, when you restock, take this out of the bag. If you coil it up and take this valve here, this is the patient valve. If that goes in the L portion of your sleeve on your bag here, and these front packages are all Velcroed, so make sure it's sitting like an L. There's a whole reason for doing this. If you coil the circuit up, it gives you a spot to store that medium mask and HEPA filter right in the center here. The purpose of that is if you just shove everything in, memory foam takes whatever form it's set at. So if you have this mask and it's sitting in your bag and it sits like this for a month before you go to use CPAP, it'll stay crushed and you go to use it on a patient and you have to wait a couple minutes for it to finally reseat. Well, instead of waiting, just make sure you package it so that it doesn't get crushed in the first place. So see how this is packaged, coiled, and then it's stuck in the center of this coil so that it doesn't get crushed while it's in the bag. And then your small and large masks will couple inside of each other. Hey, you want to throw me that green mask right there? Couple your masks together. I do comedy later too. This will fit right on the other side here. This can all zip up in the bag. Now these backpacks have a handle on each one, so if you've got the COTS with the telescoping IV pole, you can hang this right off the pole. You've got a single shoulder strap here, which you can actually click off and wrap on something. You can set this in between the patient's legs. Once you've collapsed the cot, you can actually just set it on the floor next to them. You've got a 6-foot O2 line and a 6-foot circuit line, so you've got plenty of space to attach it. If you've got ceiling lines on in your rigs, you can do it there. So you've got plenty of different places to do this. This also has a one slip-in pouch on the side here too. So some of the cots have the curved rails at the end, foot rails. You can slide it there. Some cots have the back part of it where the patient sits up. There's a pull-out tray in the back where you keep your spare portable bottle too. Set this back there. There's so many different places to put it. I'm just showing you some of the different ways you can configure and put it. You can actually take your, well, this will probably be in your airway kit, but this could also, you could keep a spare one of these in your backpack here too as well. Questions on configuration, it's kind of up to you to determine what works best for your agency. Okay, that's it.
All right, thank you for your time.
Thanks.
Dues, 'cause